Good afternoon. My name is Anett Rancz and my thesis is the invisible presence microscopic colitis. I'm a first-year PhD student in the gastroenterology and endocrinology group of the Center for Translational Medicine. I am also part of a 12-month scientific fellowship program provided from the relationship of the CTM with the MOL Foundation for the Community, and for that I am very thankful. In my vision, there are regional physicians who educate patients to prevent the development of the disease, microscopic colitis. So my mission is providing professional knowledge to the physicians about the clinically relevant risk factors of this disease. I have two ongoing projects and I truly believe that both of them will lead us closer to my vision. My first topic is the prevalence of low bone density and osteoporosis in microscopic colitis. This project started in September 2021. In Europe, the prevalence of microscopic colitis is around 119 cases per 100,000 persons. There are many confounding factors between microscopic colitis and low bone density or osteoporosis. Both diseases are more frequent in elderly women. Moreover, women in menopause can get hormonal substitution treatment, which in turn, can cause microscopic colitis. Furthermore, budesonide, what is the gold standard therapy for microscopic colitis, it's a corticosteroid with a low systemic bioavailability. Due to its high first-pass metabolism in the liver, in a long-term therapy, it is considered to be associated with low bone density. So our aim is to assess the prevalence of low bone density and osteoporosis in microscopic colitis patients. Our clinical question is, what is the prevalence of low bone density and osteoporosis in microscopic colitis patients? We use the COCOPO framework and we have an additional backup. Our systematic search was conducted on the date of October 16, 2021 in 5 databases. We got around 3,000 hits. My search key is constructed from two main parts. The first one includes microscopic colitis and the 3 subtypes of it, and the second part contains osteoporosis or low bone density or the synonyms of them. Regarding the flowchart of the selection, my data extraction is done. So these are my results. The prevalence of low bone density is 68%, of osteopenia is 51%, and of osteoporosis, fortunately, only 11% in microscopic colitis patients. These data's comparison to matched controls are under calculation, but preliminary results suggest that the prevalence of these conditions are higher in microscopic colitis patients. The strength of this study lies within being the first meta-analysis which assessed the prevalence of LBD, osteopenia, and osteoporosis in microscopic colitis patients. On the other hand, the limitations are that we have really limited data. Most study contains a small number of patients and most of them are elderly women. So to draw the conclusion, the implication for research is that further prospective studies are needed to assess the incidence of low bone density and osteoporosis in microscopic colitis patients. The implications for practice are that our studies suggest that microscopic colitis patients should be screened for low bone density and osteoporosis. Additionally, patients with MC may be advised for lifestyle changes to prevent osteoporosis and LBD. So the main conclusion is the prevalence of low bone density is 68, the prevalence of osteopenia is 51, and of osteoporosis is 11% in microscopic colitis patients. My second topic is the risk factors of microscopic colitis. This project started in October 2021. In Europe, the incidence of microscopic colitis is around 11.4 cases per 100,000 person years. Medication use has been implicated in the development of microscopic colitis. On the other hand, BMI is inversely associated with the risk of microscopic colitis. So our aim is to assess the risk factors of microscopic colitis in adult patients. Our clinical question is, what are the risk factors of microscopic colitis in adult patients? We have the PEO, and the hypothesis is that with the presence of the risk factor, there is a higher chance to develop the microscopic colitis. So the clinical implication is that screening and prevention are necessary in case of the presence of risk factors. Our systematic preliminary research was conducted on November 18th. In 3 databases, we got around 7,000 hits, and I have already started my postgrad registration. Regarding the search key, it includes only the microscopic colitis and the 3 subtypes of it, not to miss on any of the risk factors. So my goal is to finish these projects during springtime of 2022 and to move forward and maintain a better patient care. I would close my presentation with the words of Beverly Hills, but not from Beverly Hills. There are no shortcuts to any place worth going. If anyone has questions, I'm glad to respond. Thank you.
One question. Do you know what percentage of patients with microscopic colitis are menopausal women?
There is some articles which mention that they adjusted the results for confounding factors, and I don't know the specific number right now, but there are numbers.
My question relates to the BMI. You have said that the BMI has a reverse connection with this microscopic colitis. But what is the direction? Lower the BMI, higher the frequency, or in the case of microscopic colitis, the patient lose weight?
I think that both of them is true. I mean, I do. Since there is a high number of stools per day who has microscopic colitis, so they lose weight. But on the other hand, a higher BMI actually, in the studies, are that it protects from getting microscopic colitis.
How long do we use budesonide during the treatment of microscopic colitis, and how often do we need to repeat the budesonide course?
For the first question, there is an attack dose for 3 weeks. And there is regulation dose for using for 9 weeks, if I remember it right. But I don't know the periods of time, how many times it should be repeated. I actually know that there are patients who respond really well, but there are patients who get better on 1 day, and after that they get worse, and they got a flow. I don't know if the prognosis.
It might be a very simple question, but what is the case definition and the diagnostic criteria of the microscopic colitis?
The right diagnosis can be established only after an endoscopic and only after an endoscopic examination, and only after the right histopathological examination.
And the diagnostic criteria is based on histopathology always, and is subdivided in 3 subgroups according to them: collagenous one, epicytic one, and complete one, depending on the level of the collagen and depending on the number of the intraepithelial cells per 100 epithelial cells.
My question is kind of attached to the previous question. Bearing in mind you need a colonoscopy and biopsies from the large bowel to have the diagnosis, what do you think? Is it an underdiagnosed or well-diagnosed, well-recognized disease? And do we really know the true prevalence of this disease?
In my thesis, I wrote the invisible presence. I would interpret that on two ways. First of all, it is invisible because in most cases it can be seen with an endoscopic examination. And the presence, of course, because if you get a sample and you put the histopathological examination on the right, then you have the right diagnosis. But on the other hand, the presence, I mean, first of all, you need a good GPI. After that, you need a good gastroenterologist. After that, you need the right endoscopic examination. And after that, you need a good histopathologist who put the diagnosis. So I think that it can be under-diagnosed because patients are suffering for many years until they get the right diagnosis. It happens.
I think you are absolutely right on that, and recognizing this problem, in actual fact, one of the key performance indicators of your colonoscopy practice, if you're a colonoscopist in the UK, you are measured, and you will be measured if you do biopsies for all patients who have diarrhea. So if you are not doing 100% biopsies for patients who are doing colonoscopy for diarrhea, you will get a notice that you are not doing good colonoscopy. So I think it's important to understand that it's a largely underdiagnosed disease, and it's probably the burden from this disease is much bigger than what we actually see. Absolutely right.
It definitely reduces the quality of life as well.